to all. Okay, so it's on now. Okay.
Welcome everybody. Bonsoir tout le monde et bienvenue à notre discours annuel, Hirsh Rosenfeld. Good evening everybody and welcome to the annual Hirsh Rosenfeld Public Lecture. I'm Marian Dove. I'm the chair of the Department of Family Medicine at McGill University. And I am delighted to welcome you all here for the public lecture. We have an excellent speaker for you this evening. And prior to turning the floor over to her, we will have Mr. Samuel Brauman from the St. James Literary Society, which is co-hosting tonight's event with us, say a few words. So Mr. Brauman, would you like to go ahead?
Bonsoir, mesdames et messieurs. Je suis le directeur de programme pour la Société littéraire St. James. Au nom de notre président Kevin Journeau, j'ai l'honneur de vous souhaiter le bienvenu et j'espère que vous allez passer une soirée très agréable. Good evening, ladies and gentlemen. My name is Samuel Broman, and I'm with the St. James Literary Society. Welcome, and a special welcome to our distinguished guest speaker, Dr. Rianne Towers. Just a few words about the St. James Literary Society. We're a nonprofit organization founded in Montreal in 1898. Our motto is Permite Lucem, which means let there be light. Our mandate is to provide a forum for the free exchange of ideas between the guest speaker and the audience. Over the years, we have been honored by the presence of such prestigious speakers as Wilder Penfield, Phil Gold, Stephen Jaroslavsky, F. Cyril James, Heather Monroe Bloom, Suzanne Fortier, John Diefenbaker, and the list goes on and on. Just before I finish my remarks, I would like to make known that we at the Literary Society are very glad to be participating, collaborating once again with the Department of Family Medicine at McGill, as we have done in many times in the past. The next speaker will be the chair of the Department of Family Medicine, Dr. Marian Dove.
Thank you, Mr. Brown, for those remarks. I would like to introduce Professor Rianne Touyz, who is our guest speaker this evening. So Dr. Touyz is the Executive Director and Chief Scientific Officer of the Research Institute of the McGill University Health Centre. And she is also the Dr. Phil Gold Chair in Medicine at McGill University. Until September 2021, she was the Director of the Institute of Cardiovascular and Medical Sciences and the British Heart Foundation Chair and Professor of Cardiovascular Medicine at the University of Glasgow in Scotland. From 2005 to 2011, she held a Canada Research Chair in Hypertension. She is a clinician-scientist with an interest in molecular and vascular mechanisms of hypertension and small vessel disease, and her research spans molecular to clinical studies. Dr. Touyz graduated with her Bachelor of Science in 1980, and then did a master's in 1984, a second master's in 1986, and a PhD in 1992, all at the University of Witwatersrand in South Africa. She completed a postdoctoral fellowship at the IRCM in Montreal, and subsequently has received numerous awards. She is currently the editor-in-chief of Hypertension. She contributes to best clinical practice and co-chaired the CHEP for clinical guidelines. She's a member of the guidelines of the European Society of Cardiology. She played major leadership roles in premier hypertension organizations, being president of the Canadian Hypertension Society, chair of the BP Research Council of the American Heart Association, president of the International Society of Hypertension, and president of the European Council for Cardiovascular Research. So if you want to hear some numbers, she has trained over 80 PhD and medical students and fellows, and has published over 570 papers on hypertension. So again, her research focuses on molecular and vascular biology of hypertension and target organ damage, particularly vascular signaling and redox biology, adipose biology and cardiometabolic disease, cardiovascular toxicity of anti-cancer drugs, and the pathophysiology and management of human hypertension. So Dr. Touyz is a renowned expert in this field, and she will speak to us tonight on hypertension, why you should know your numbers. So again, if you have questions, please hold them for the end, and we'll have a question period after she has given her talk. Dr. Touyz.
I think I can take this one. So good evening, everybody. And before I start, I need to apologize for my hoarse voice. This isn't my usual voice, but I've just returned from the UK with a cold, but I can assure you that it's not COVID. So please be reassured about that. I'm absolutely delighted to be here this evening. And really, even if I had to be pulled from my bed, I wouldn't have missed coming to be here. So thank you, Marian, and the organizers of this very special event for inviting me to give this talk as part of this wonderful series. So indeed, I'm going to talk about high blood pressure or hypertension, why it is a killer, and why it's so important that you know what your blood pressure is. And I just want to highlight to you that I don't have anything to declare. There's no conflict. So in order for us to start and appreciate Hirsch Rosenfeld, the man who really has played such an important role in both medicine, in cultural activities, educational activities in Montreal. A little bit about him is that he came from Eastern Europe. He came to McGill to do a Bachelor's of Arts degrees. He studied medicine in Strasbourg, and then he came back to Montreal where he worked as a doctor. He founded the Doctors' Hospital for Poor Immigrants, and I tried to find some information about this Doctors' Hospital, but unfortunately there wasn't anything in the literature about this, so it would be very nice to know what the Doctors' Hospital actually became. But he obviously was a very sympathetic individual who was very caring for those who were less fortunate. He supported many cultural, educational, and community activities, as we can see here. And as I've said, there are many educational and cultural awards in his name. And so really, Hirsch Rosenfeld, and I learned this only very recently, could be really considered a true pillar of the Montreal community. And therefore, I'm really extraordinarily happy to be able to present this lecture in his name that is being supported, as we heard, by the McGill Department of Family Medicine in collaboration with the St. James Literary Society. And as I read, Mr. Brauman, this is the oldest society, literacy society in North America, having started in 1898. So it's especially nice to be able to be here today and to talk in honor of Mr. Hirsch Rosenfeld. So over the course of the next 40 or 45 minutes, I'm going to describe what blood pressure really is. We hear a lot about this, but what is blood pressure? What is hypertension? I will talk about the complications of hypertension, the global impact of hypertension, the risk factors associated with hypertension, and I will then finish my talk with the next frontiers in hypertension. So to understand anything related to blood pressure, we have to appreciate what we mean by the cardiovascular system. And the cardiovascular system, from a very simple point of view, comprises the heart, the arteries that come out of the heart, and the veins which carry the blood back to the heart. And this really, from a very simplistic point of view, is what we call the cardiovascular system. And it's this system that is fundamentally involved in the regulation of blood pressure. Furthermore, and very importantly, the cardiovascular system is also a target of high blood pressure. And I will get onto that a little bit later. So when we talk about blood pressure, the definition is when the heart pumps blood through the arteries being the red tubes, as we can see here, the red vessels. When the heart pumps blood through the arteries, it exerts a pressure on the arterial wall. And this is what we refer to as blood pressure. Now, the cardiovascular system or the circulatory system comprises large arteries, such as those that we know as the aorta, for example, or the carotid arteries. And it is these large arteries that directly take the blood from the heart to the different organs in the body. In addition, of course, to these large arteries, we have lots and lots and lots of small arteries. And the small arteries play an absolutely critical role in supplying every cell, every tissue, and every organ in the body with blood, nutrients, and oxygen. So again, the heart, the large vessels, and then the large vessels feed into the small vessels that feed into the vessels of the brain, the heart, the kidneys, and the periphery. So you can appreciate that if it is these small vessels that are so important for supplying oxygen and nutrients to the different tissues and organs, if there's any perturbation or disruption or abnormality in this blood flow through these small vessels, this can result in enormous tissue damage and even in tissue death. So the pressure that is exerted, as I said, in the lumen, in the center of the vessels, on the outside of the wall, is what we refer to, as I said, the blood pressure. And we talk about two values when we speak about blood pressure, an upper level and a lower level. The upper level is what we refer to as the systolic blood pressure, and the lower value is what we refer to as the diastolic blood pressure. So when you go to the doctor will report to you that your blood pressure is 124/82, systolic over diastolic. What does that mean? What that means is that the upper number, or the systolic blood pressure, occurs when the heart is beating, when it's contracting. When the heart relaxes, this is what we refer to as the diastolic blood pressure. So when the heart relaxes, the pressure becomes lower. And the ideal blood pressure that we refer to today is that of 120/80 millimeters of mercury. And I truly hope that everyone in the audience does know what their blood pressure is. And I would be delighted if you told me that your blood pressure was less than 120/80, because that is the blood pressure that we all strive for. You've got 120, fantastic. I hope all of you have got a blood pressure of 120/80, excellent. So if normal blood pressure or ideal blood pressure is 120/80, what do we consider as abnormal or high blood pressure? And remember, the pressure is that pressure that is exerted in the middle of the vessel. So if the pressure gets higher, you can imagine that it's going to cause injury to the vessel wall. Today, we consider hypertension as being a blood pressure of greater than 130/80 millimeters of mercury. For some, this might be a relatively new concept. For the clinicians, you may be familiar with the older definition of 140/90, but today we strive for a blood pressure of 130/80. And I just want to present to you some data to show you that blood pressure increases with age. And we can see here at the bottom, this is increasing age from 20 years to 55 years. And over here on this axis, we've got the number of patients, if you like, or the number of events associated with hypertension. And what we can see is that this graph, this red graph, represents Black men, as they get older, their blood pressure events are very, very high, higher than that of Black women, as you can see by the spotted red graph, higher than that of white men, and white women actually, as a population study, have lower blood pressure than these groups together. And there are reasons for that. We know that blood pressure in the earlier years of life, as we can see here, between men, the dark gray, and women, the light gray, from about 20 to 50, women have a lower blood pressure than men, as we can see. Here we can see from the ages of 20 to 30 to 40 to 50, lower blood pressures in women than in men. But from menopause, we can see that blood pressure in women starts to track similar to that we see in men. So as women become older, their blood pressure starts approaching that of men. We think that one of the reasons for this might relate to changes in the hormone levels, the sex hormone levels, because we can see, if we look at this black graph over here, with aging, the concentration or the levels of estrogen significantly decrease with aging, exactly at a time when blood pressure in women increases. We see actually a similar trend in men with testosterone. With aging, testosterone also decreases, and actually we think that this too is associated with the increasing hypertension as men get older. So there is a relationship between aging, between sex, and between blood pressure. I think that one of the easiest ways to explain the consequences of high blood pressure is if we consider what happens if we look at a tap and a hose pipe. And if we consider that the tap that is producing the water is the heart, which is linked to the hose pipe, which in the body would be considered as being the blood vessels, you know that if you change the amount of water coming out of the tap, the amount of water coming out of the hose pipe will also be altered. You can see that if a small amount of blood or a small amount of water comes out of the heart or the pump, a small amount of water will trickle through the hose pipe. Similarly, if we constrict this hose pipe, we make the lumen smaller, we can appreciate that there would be an increase in the pressure in that hose pipe. And so this will result in huge damage to the pipe. And this is exactly what happens to blood vessels when they get exposed to very, very high pressures, as we will see a little later. So high pressure in vessels causes injury at the level of the blood vessels themselves. So what do we know about blood pressure and its significance in terms of hypertension, in terms of its history? The concept of healthy blood pressure and the importance of hypertension is not new. Already in 2600 BCE, the Chinese Yellow Emperor's Classic of Internal Medicine actually said that if too much salt is used in blood, the pulse hardens. And the treatment of a heart pulse disease includes acupuncture and bleeding by leeches. This was BC 2600, a long time ago, already suggesting that salt is not good for the vessels, the heart, or the blood pressure. In 1550 BC, the relationship between the palpated pulse and the development of heart and brain disease was already appreciated, as indicated by the Egyptian physicians. So blood pressure was really appreciated many years ago as being critically important for normal health. And it was only in 1628 when William Harvey actually described the circulation of the blood in a book that he produced. Excuse me. Sorry. And then in the 1700s, for the first time, blood pressure was actually measured. And this was measured in a horse by Reverend Hales. He inserted a tube in one of the arteries and he measured the pressure. And the pressure was reached at 8 feet. The pressure that was induced by the heart, by the vessels, it measured 8 feet and 3 inches. So you can appreciate how much pressure was involved in getting the blood to that level. And more recently, we know that hypertension is a clinical entity.
Take your time.
Sorry. And today we talk about contemporary hypertension and its treatment in terms of medication and surgery. I think I'll just take 5 minutes break.
So yes. So.
Brianne, do you want warm water?
No, thank you. I'm getting so excited.
The picture of the horse. I don't know. It said they put the tube in the artery, and like for medical students, something that we learn when we put a tube into the spine and measure the pressure in the cerebrospinal fluid. So it's a similar concept, measuring the pressure.
I wonder how the horse did afterwards.
I'm guessing the horse was maybe sacrificed. Maybe the artery was repaired.
Oh, I apologize.
No. Do you want some more tissues or something?
Maybe just another water.
Yes.
So you can all start thinking about your blood pressures. Yes.
You want something warm?
Sorry about that.
No. Sorry. This is one of the things that we forget about with in-person events.
Yeah.
We're all human beings.
Right, let's carry on. Okay, so really the bottom line is we've known about blood pressure for a very long time. And as I said, it was in the early 1900s that we started to have machines to measure blood pressure. And as clinicians, we can measure blood pressure using what we call a sphygmomanometer. And then in the 1910s and then 1940s, drugs to treat high blood pressure were starting to be developed. And in the 1950s, we had for the first time antihypertensive drugs. Now, the consequences of hypertension are enormous because if you remember, I said that if the pressure is too high, it causes injury of the vessels themselves, but also injury of their target organs that they supply, such as the brain, the heart, the kidneys, and in fact, all organs and tissues. And the impact of hypertension is particularly relevant when we look at this photograph, which was taken at the Yalta Conference in 1945 at the end of World War II. We can see three very famous men. You can think who they are. Remember, normal blood pressure is 120 over 80. Look at their blood pressures. So,
Roosevelt was the first to die.
absolutely. So, they all had hypertension at this meeting. 2 weeks after this meeting, we can see Roosevelt went to have his portrait painted by an artist. The painting was not finished, unfortunately, because while he was sitting to have his portrait painted, he said, "I've got a terrible headache, a terrific headache," and he collapsed. And his blood pressure was measured by his physician as 300 over 190 millimeters of mercury. I can't imagine that such a reading can actually be taken, but nevertheless, we will take it as being significant. But the bottom line is that these three men had severe hypertension and all of them died of a stroke. If one looks at the history of these three men, it's quite interesting. They were obviously very proud men. They didn't like to be told what to do, and they didn't take the antihypertensive medication. So there you go. So, as I said, these three men had high blood pressure and they all died of stroke. I want to reiterate that high blood pressure or hypertension has an impact on the brain, an impact on the eye, impact on peripheral vessels, the legs, the arms, the kidneys, and the heart. And we know clinically that patients who've got hypertension are at increased risk of developing a stroke, vascular dementia. We know that they're more exposed to retinopathies, problems with the eyes, that high blood pressure can lead to an enlarged heart, can lead to what we call ischemic heart disease or blocked blood flow to the heart. As I said, high blood pressure can affect the kidneys, causing kidney failure. Importantly, high blood pressure can also cause enlarged arteries, of the big arteries especially, causing aortic aneurysms. And so you can see and you can appreciate why having high blood pressure is so dangerous, because it is a major risk factor for all of these conditions, which are major causes of both morbidity and premature mortality in the world. So there are some good things and some bad things about hypertension. The good thing is that there are no symptoms, so patients feel very well. The bad thing is that there are no symptoms, so patients don't know that they've got high blood pressure. And as clinicians, we know that for many of these patients, the first time that they may be made aware of the fact that they've got high blood pressure is when they arrive in the emergency room with a stroke, a heart attack, or kidney failure. Or as we saw with Roosevelt, he had a stroke while having his portrait painted. That was, uncontrolled hypertension. So indeed, because there are no symptoms, this is why we call hypertension the silent killer. It kills without the individual, without the patient having symptoms. I just want to highlight some statistics regarding hypertension. For about 7 of every 10 people having their first heart attack will have high blood pressure. 7 out of 10, 70%. About 8 of every 10 people having their first stroke have got high blood pressure. And about 7 of every 10 people with chronic heart failure have got high blood pressure. So as I said, again, many of these diseases, and especially these are diseases that are chronic and that occur with increasing age, are associated with high blood pressure. So what does this look like in terms of the global impact of the important conditions associated with morbidity and mortality? And these are statistics that are taken from the global perspective. And what we can see is that high blood pressure is the major cause of morbidity and mortality in the world. It's not cancer, it's not infection, it's not trauma, it's high blood pressure. And the reason for that is because high blood pressure causes heart disease, stroke, and kidney failure. So hypertension is very common. In an older in the community, 1 in 3 individuals would have hypertension. It is very, very common. In adults, 1 in 3 has high blood pressure. And for the clinicians, if you can appreciate, these statistics were based on a blood pressure of 140/90. So the numbers are more than 1 in 3. Hypertension, we thought many years ago, was a problem of the developed world, of the Western world, of the communities that we're familiar with Westernized societies. But we know today that hypertension is increasing in the low and middle income countries. And this is a map of the world. And what this map shows us is that the darker the red color, the more prevalent is hypertension. And what is very interesting to notice is that years ago, we would have seen red a lot in Canada and in the United States. We're now seeing a lot of hypertension in South America, in Asia, and in Africa. So hypertension is not only a problem in the Western world, but it is becoming increasingly a major problem in the low and the middle income countries. Again, some numbers so that you can appreciate the importance of hypertension in the world. It's predicted that the worldwide increase in patients diagnosed as having hypertension will reach about 1.6 billion. Again, based on old definitions, this will probably be more based on the new definitions. And as I said, the hypertension-associated morbidity is what is ultimately responsible for the complications associated with death. So why does it matter? Why does this all matter? Well, it does matter because I've just told you that as you get older, the number of patients who will have a cardiovascular event increases significantly, both with the systolic blood pressure, especially, but also with the diastolic blood pressure. And this is just another graph to show you that the consequences of hypertension in different age groups, even in younger age groups from 20 to 30 to older individuals, this graph actually shows you the impact on ability to work in different countries due to hypertension. Again, the impact of hypertension is enormous in terms of quality of life. So if high blood pressure is so important, and we know that as blood pressure increases, so too does the association with both ischemic heart disease or heart attacks and stroke. We can see even at a lower blood pressure, there's an increased association with these complications. So the question we have to ask then is, what is the optimal blood pressure to prevent these cardiovascular events? We know high blood pressure is bad.
Yeah.
We know that even at the lower pressures, you can have events. So what is the best blood pressure? And I've already told you what it is. But how did we get to know that 120/80 is what we should be striving for? Well, I'm going to share with you a study that was very, very important in the world of hypertension. This study was called the Systolic Blood Pressure Intervention Trial. And I will try and simplify the study But it really is an important study, especially for the clinical folk who may be interested in hypertension and hypertension treatment. In this study of about 9,500 patients, these were patients that were treated with hypertension by their family doctors, and the only intervention was that the doctor was told to treat the patient intensively or just use standard care. Use any antihypertensive treatments that you want, but make sure that in the intensive treatment group, blood pressure is aimed at being less than 120/80, as we can see here. And this was the standard blood pressure treatment group. And what the study did is it tracked the complications or the cardiovascular events in these two groups over, initially it was supposed to be for 5 years, but the study was stopped early at 3.5 years, because we can see very clearly that those patients who had their blood pressure treated intensively, their cardiovascular events were significantly less, as we can see here, when their blood pressures were targeted to 120/80. Again, these are two graphs to show you that death in the standard treated group compared to death in the intensively treated group, there was almost a 30% reduction based only on a blood pressure target of 120/80. And this was a paradigm shifting clinical study in the world of hypertension. And based on that, we started to have new blood pressure guidelines. And the guidelines today, as I said, are that we consider normal blood pressure to be 120/80 and hypertension stage 1 to be 130/90 or 80/89. So if you're sitting in the audience and your blood pressure is 132/86, by definition, you would have high blood pressure. And as physicians, the dilemma starts, we start having the dilemma as to what do we do with those patients who come in healthy and those blood pressures that by definition are hypertensive. So where do we stand today in terms of treatment of hypertension? Well, I can tell you that we've known, as I said, about hypertension for a long time. Actually, treatment of hypertension could be considered as one of medicine's major successes over the past 50 years. Why is that so? Because there have been enormous advances in the drugs that provide capacity to lower blood pressure in almost every patient. So we've got many different types of antihypertensive drugs available to us that we can use to treat patients with hypertension. However, despite the fact that there are so many different types of antihypertensive drugs available, uncontrolled disease remains despite improved therapy. And Chobanian, at his Shattuck lecture a few years ago, defined this as the hypertension paradox. So what are the reasons for the hypertension paradox? Well, hypertension is a multifactorial disease. There are many factors that cause or contribute to hypertension. There are many environmental factors that can impact blood pressure regulation. Perhaps we don't have the best therapies yet. Adherence and compliance is a major issue. Patients don't like to take their tablets. And at the end of the day, the pathogenesis, the underlying etiology still remains unclear. And it is for this reason that there's been huge amount of effort to better control, better treat patients. And actually, if we look at these studies, and these were studies that came out of the US, they showed us that over a period of time from the 1990s to 2013, the number of patients that were treated and that had controlled blood pressure was actually increasing. But then something happened in 2015, 2016, and that is that blood pressure control started to decline. And we have seen something very similar in Canada, especially in women. And there was a paper that came out in the Canadian Journal of Cardiology. And in America, because of this, the Surgeon General put forward a call to action to control hypertension. And this became a national commitment to improve care in patients. So what is it that is causing high blood pressure? Well, as I said, unfortunately, we still do not know. Nevertheless, it was in the 1960s that Irvine Page started to appreciate that there were many factors that do play a role in the regulation of blood pressure: genes, environment, anatomical processes, neural processes, and hormones. And he put together this concept of what we call the mosaic theory of hypertension. Many factors playing a role. And this is what the mosaic looked like in the 1960s. It was quite innovative. It was quite complex in those days. However, what do we know about processes that contribute to hypertension today? It's become much more complicated. Many genes have been identified. Many new signaling pathways have been identified. And so today we have to consider the advances in the field in terms of putting this mosaic together. And for this reason, we have now redrawn the mosaic of hypertension to include some new concepts related to the pathophysiology of hypertension, including inflammation, the microbiome, oxidative stress, and other factors which in the past one would not have considered as being important in the pathophysiology of hypertension. However, I can't reiterate enough that despite all of this research and despite all of these advances, there are still two types basically of hypertension that we talk about: essential or primary hypertension and secondary hypertension. And the garden variety hypertension that the majority of people have is what we call the essential hypertension, where the cause is not known. In 95% of patients, we do not know the cause of the high blood pressure. In only 5% of patients, we know what the cause is. And if we correct the cause, we can cure the high blood pressure. We cannot cure hypertension in the majority of patients with hypertension. So before we even consider hypertension, we've got to make sure that blood pressure is measured in the right way. And you would be surprised how many people have their blood pressure measured by the doctor or in the clinic, and blood pressure is not taken correctly. So there are now a number of guidelines to tell us how to measure blood pressure correctly. And I can't stress enough the importance of having a good back rest when you measure blood pressure, and also to make sure that blood pressure, of course, the cuff is at the level of the heart. So taking blood pressure is very important. And today we use automated systems, which actually has also played a huge role in the diagnosis of hypertension. In the past, we used the sphygmomanometer to measure blood pressure. Today, at least in the research environment, we use a number of very sophisticated technologies to actually help us assess the vasculature and other markers of vascular and organ damage, as we can see here, very sophisticated. And these are just some of the techniques and tools that we have used to look at what blood vessels look like, because to remember, I said that blood vessels undergo injury when blood pressure is high. And we can look at imaging of vessels, we can look at the function of vessels, the function of the endothelium, and this gives us a really good idea in terms of underlying pathophysiology. So what can we do to treat hypertension? Hypertension can be managed by what we call non-pharmacological or non-drug therapies, also what we call lifestyle modifications, and pharmacological therapy or drugs. And we've got many, many, many different drugs available to us, as I mentioned just a little earlier. But what about these lifestyle modifications? Because we often get asked, how can I prevent developing high blood pressure? How can I protect my blood vessels from becoming damaged? Well, these are the lifestyle modifications that have been proven to show that if you address these, blood pressure can be controlled. A good diet, reduced salt intake, increasing exercise, weight loss, reducing alcohol intake, smoking cessation. And now today, we also know that environmental pollution can play a role in hypertension. And so improved air quality is also now being considered as a parameter that we might have to consider for improving cardiovascular health. So I also want to emphasize to you that even if you reduce blood pressure by just 2 millimeters of mercury, the consequences with respect to preventing complications of hypertension is enormous. Simply reducing blood pressure by 2 millimeters of mercury, so going from 140 millimeters of mercury to 138 millimeters of mercury, for example, can reduce ischemic heart disease events by 7% and stroke by about 10%. So at a population level, this is enormous and has a huge impact. I want to talk just a little bit about salt, because salt is a very controversial topic in this world, as you know. But from my point, from the evidence, there's a very clear association between salt intake and blood pressure. And this is just one example to show you in individuals where the amount of salt that was excreted through the urine was measured and associated with blood pressure. And we can see that the higher the salt in the body, or the salt in the urine, the higher the blood pressure, a very close association between sodium or salt concentration and blood pressure. So how do you control for salt intake? Well, interestingly, the amount of salt that we eat in our food is present mainly in processed foods. About 70 to 80% of the salt or sodium that we take into our diets is in processed foods. Anything in a box, a tin, a packet, even frozen foods have got salt added, either as a preservative, sodium benzoate, for example, sodium chloride. All of this contributes to the sodium or salt content of the food. Naturally occurring salts in vegetables, etc., about 14%. Salt that's added at the table, very little actually. So therefore, controlling the amount of processed foods that we eat is really what we should be doing in terms of reducing our salt intake. And we can see in this diagram that those foods that have got the highest salt content are breads and cereals. Breads and cereals have got a huge amount of sodium. Preserved meats, pizzas, all the things that I guess everybody loves to eat. All of these foods have got a very high salt content. So this is just an example to show you how much blood pressure can be reduced without taking any drugs, but by simply doing lifestyle modifications. And you can see that dietary changes, if you have a healthy diet, what diet we call a diet that is the diet to approach to for systolic hypertension, it's a diet which in vegetables, fruits, fresh meats and fish, blood pressure can be reduced as much as 11 millimeters of mercury. But also exercise, alcohol intake, reduced salt intake, and weight loss, all very important for reducing blood pressure. But we can't do that usually alone, and very often we have to go on to using drugs to treat hypertension. And as I said, the first drugs to treat hypertension were made in the 1950s. But since then, we've had a whole host of new classes of very, very effective antihypertensive drugs that have been developed. And today, as I said, we've got a whole armamentarium of drugs that can be used to treat hypertension. But despite that, and again, I can't emphasize enough, despite that, very few of the patients who actually have hypertension, who are treated, have blood pressure treated to target. In this study, and this study is representative of many studies, the number of patients who are treated for hypertension is only about 15%, which is actually very, very low. That means so many patients are at risk of cardiovascular events, and that's why our wards and our emergency rooms are so full of patients with heart failure, ischemic heart disease, and strokes. Despite all of this, we are still not achieving what we wanted to achieve. So why, if we've got all these drugs, high blood pressure is so prevalent, the complications are so enormous, and we know that if we control hypertension, we can prevent these complications, which could have a huge impact on social, on economic, on personal well-being. Well, we're beginning to understand now that not all patients respond the same way to hypertension medication. A tall person, a short person, a fat person, a thin person may not respond the same way to hypertension. And this takes us to the next frontiers in medicine. And this is what we call precision medicine. And you might have heard of this new concept in medicine, where we should be able to treat a patient in a very, very specific way so that the treatment is only specified for that individual, precision medicine. There are also new therapeutic strategies that I'll briefly mention. And also, we have to think now about other strategies to treat hypertension besides drugs. So precision or personalized medicine, or precision or personalized hypertension, as I said, is the right treatment for the right patient at the right time. So you see here, we've got blue people, red people, pink people, purple people, and light blue people. Today, we would treat all of these people with the same drug. But actually, these people have different pathophysiologies, different pathoetiologies, and they will not all respond the same way to the drugs. Our goal is to find something such that we will be able to treat each patient for their specific phenotype. Precision hypertension. We are getting there. How are we getting there? We're getting there by understanding more about their genetics, about their proteins, about how they metabolize factors in their body. And the more we understand about this, the more we'll be able to very carefully phenotype patients such that we will be able to treat them much more effectively. In addition, a very, very, very exciting time in the world of new therapies in hypertension, the concept of a vaccination or RNA, targeting the RNA. You've all heard about COVID and the vaccines we use targeted to the RNA. A very similar approach is being used to treat hypertension, and the trials are very exciting. And again, for the clinicians, this is a new field where siRNA is used to downregulate angiotensinogen in the liver, and this causes a downregulation of angiotensin II. You need one or two injections a year, and blood pressure is maintained. How marvelous is that, really? Also, devices. We know that renal denervation is becoming more and more interesting. Some of the new trials have been very efficacious, and there are a whole lot of other new devices that are being developed for the treatment of hypertension. So I'm going to finish now just to say, really, that the number one killer in the world is hypertension, because it causes heart disease, stroke, Vascular dementia, we know today, is a consequence of high blood pressure. It causes kidney failure. It causes, it predisposes as well to atherosclerosis in arteries. It's important that you know your blood pressure because there are no symptoms associated with hypertension. Those who have hypertension know what to do to reduce the risks of cardiovascular disease and hypertension. And if you are hypertensive, it's important to take your medication. And again, because of the more recent appreciation of the global impact of hypertension, the World Health Organization, the World Hypertension League, and other national, international organizations are now putting a huge amount of effort into having a 2025 or 2030 initiative to reduce blood pressure, to prevent cardiovascular disease, and to make treatments and better social economic environments available to communities at large. So there are big initiatives and there have been some successes. Also, just to highlight this, as part of my role in the International Society of Hypertension, we became very involved in trying to advocate for hypertension globally. And every year in May, we have World Hypertension Day or World Hypertension Month, where we really advocate and lobby for people in different countries across the world to measure their blood pressure. And it's an ongoing and growing program. So with that, thank you for your attention and we'll be happy to answer your questions.
Very much, Leanne. That was fascinating, and there are multiple questions in the chat, but I thought maybe we'd give an opportunity to people in the room if anybody wants to ask a question. Yes, please go ahead.
Every time I go to the pharmacy, I use one of those little devices there to measure my blood pressure. I tell my physician this, and he says, he takes my blood pressure anyway, and he says those machines are not really effective. What do you think of that? Measuring your blood pressure on a regular basis.
I think, yeah. What we suggest is that you should measure your blood pressure at home. And actually, there's more and more emphasis now in terms of diagnosing hypertension based on blood pressure measurements at home, because we know actually that the home blood pressure is a much better reflection of the patient's or the individual's blood pressure under normal circumstances. So the guidelines across the world advocate for measuring blood pressure at home. And today there are many different types of blood pressure devices that you can get to measure blood pressure, or in the pharmacy, that's fine as well. It's important that the blood pressure machine that is purchased is a blood pressure machine that is validated. You don't want to get a blood pressure machine that's going to give you, the wrong numbers. So it's very important. And the Canadian Hypertension Society, well, there will be a little mark on the product to say this has been validated by Hypertension Canada or the Canadian Hypertension Society. So if you are able, it's really important to have a home blood pressure monitor and to measure your blood pressure regularly. You can discuss with your doctor how many times you should measure it. But the one point that I always like to tell my patients is that when you measure your blood pressure, make sure you measure it at the same time of day every time you measure it, because that way you can compare blood pressures from day to day. I also want to emphasize that blood pressure does vary during the day and the night. And very often a patient will come and say, oh, my blood pressure is changing, going up, going down. It's normal. Blood pressure does vary with different activities and during the course of awake and at night. So measure blood pressure the same time of day if you are measuring your blood pressure at home. The other thing is your blood pressure is highest when you wake up at about 5 or 6 o'clock in the morning. That is when blood pressure is highest. And we think that is why cardiovascular events, stroke or a heart attack, usually happen during that time period. When we measure blood pressure for 24 hours, and we've got different devices we can do that, we can see that blood pressure increases in the early hours of the morning.
Question, so do you recommend like the best time to measure your blood pressure if you're doing it at home with the device is when you wake up in the morning to start your routine?
You say what time is the best?
Yes.
Yeah, I usually say in the morning when you wake up, because that will be your highest blood pressure. And then I just say to the patient, make sure you measure at the same time every day. In some cases, especially if there's blood pressure is not well controlled, measuring it twice a day sometimes may be important. The other thing is you've got to be sure some patients don't get very nervous and very anxious when they have to measure their blood pressures at home, and we don't want it to become a negative experience either. But I like to say measure it in the morning, which is when your blood pressure is usually highest. Yeah.
So we have an interesting question in the chat. Well, we have many interesting questions in the chat, but one of the first ones is it dangerous to have low blood pressure around 100 on 60? And are there any important implications on low blood pressure?
Okay, so low blood pressure. So low blood pressure only becomes a problem when you have symptoms, and you will have symptoms of very, very low blood pressure. And this usually means that you've landed up in the hospital in the emergency room. And this is usually when your blood pressure is maybe 50 or 60 over 20 or 30, very, very low blood pressure. For all intents and purposes, lower blood pressure, such as 106 over 60, is fine. It's not considered hypotension unless the individual is symptomatic, is continuously fainting or falling or continuously dizzy, then it might be a little bit of a problem. But for all intents and purposes, lower blood pressures are not a problem.
The next question is, do you adjust the normal range of blood pressure as one ages? For example, do you consider 120 on 80 a normal blood pressure for a 90-year-old?
That is a very, very important question. You see, we've come a long way as clinicians and researchers in the field, because I can tell you it wasn't that long ago that we did have different cutoffs for different age groups. For example, in an older or very elderly individual, we would say that a blood pressure of 140 over 90 is okay. However, there have been a number of excellent recent clinical trials to show us that in patients who are elderly, over 80, and who are not frail, in other words, who don't have other comorbidities or who are ill, one should still strive to get blood pressure to targets of 120 over 80.
The next question is the 24-hour blood pressure testing a gold standard for diagnosis?
We use the 24-hour monitoring. It's an excellent parameter that we have, and it provides an enormous amount of information. We as clinicians diagnose hypertension using a variety of different measurements. We can diagnose hypertension in the clinic using a standard blood pressure machine. We can diagnose hypertension based on blood pressure readings that the individual records from home blood pressure readings. And then, of course, we've got the 24-hour blood pressure monitoring. And indeed, that is what we consider the gold standard, especially in patients where we are not sure if they do or they do not have hypertension. The 24-hour monitoring is really useful because not only does it tell us about what we call diurnal variation in blood pressure regulation. We know blood pressure is higher during the day, it goes down at night. And as I said, it will go up in the early hours of the morning. That's what we call a normal diurnal variation. If the blood pressure of a patient is up in the day and doesn't go down at night, that is what we call a non-dipping blood pressure reading. And that is bad because those patients are more at risk of a cardiovascular event. Sometimes blood pressure is higher in the night than in the day. And that's even worse because these patients are at increased risk of cardiovascular events.
The next question is, when you have an elevated blood pressure, do you need to take medication or control by other means such as diet and exercise?
Okay, so what is suggested is that everybody should live a healthy lifestyle. That means we should all be exercising, eating a healthy diet, not having too many processed foods because you don't want to add salt. So we should all be having those healthy lifestyle modifications, as I mentioned to you. Some patients, some individuals can control their higher blood pressures purely by lifestyle modifications. We have seen that. It demands a lot of effort, but you can control hypertension with lifestyle modifications. However, very often it's necessary to add an antihypertensive drug as well. So we also know that patients who have lifestyle modifications, in other words, have a healthy diet and exercise and all of that, they need less antihypertensive treatment than if they didn't have the healthy lifestyle.
This is going to require a little bit more philosophy. So how do you see the roles of socioeconomic factors in the development and treatment of hypertension?
Very important question. As you'll appreciate, I tried to show you that in the past, hypertension was a problem in the Western world. We know today that it is a major problem in poor countries where the social, the economic, levels are low. So by improving all of the social, environmental, economic factors, there's a close association with improvement in not only non-communicable diseases, but also communicable diseases. So both infectious diseases and what we would call chronic diseases such as hypertension. So the impact of social activities, environmental factors, health economics, and all this definitely does play into these factors. Chronic diseases, I think, at large, and especially now with the increasing evidence of environmental air quality, it's another factor that seems to be playing a very important role in chronic diseases as well.
Do you have energy for a few more questions?
Sure.
Okay,
Yes.
they're just pouring in. So interesting question. How much can blood pressure normalize with treatment of sleep apnea with CPAP?
Yeah, CPAP is very, very effective for managing hypertension.
CPAP is a mask that you wear on your nose and mouth to keep your airways open in your sleep.
Yeah, we know that sleep apnea is closely associated with hypertension for various reasons. And CPAP not only improves breathing, but it has also been associated with improved blood pressure control. Yeah.
Okay. How do you manage variable blood pressure?
It's very difficult. Managing labile hypertension is not easy, but sometimes by working out what the lability is and when the pressures are highest or lowest, one can just modify the timing of the tablet of the drug. And that can make a huge difference by simply switching a tablet that you would have taken in the morning to, say, the evening, sometimes works very, very, very well. And what's marvelous about the drugs we have today is that many of them you only need to take once a day because they have an effect over the 24 hours, if you like.
There's just two more questions, so we'll wrap up after that, but I wanted to give the audience here another opportunity if anybody here in the room had a question. Yes.
I found it interesting that you mentioned there's a vaccine for high blood pressure.
Yes.
Is it available?
Not yet, it's still being tested.
What's the question?
The injection to treat hypertension. This is really the new frontiers in hypertension research. It's an injection that is given, and it reduces one of the hormones that causes high blood pressure. It's the hormone is called angiotensin. We use a number of drugs today called angiotensin converting enzyme inhibitors or ACE inhibitors. Some of you may know about that, or angiotensin receptor blockers. These are drugs that will reduce the effect of this hormone called angiotensin. Now, an amazing company has developed a system where they can inject something into the body that will target the enzyme that produces this hormone. And it reduces the level of the hormone, and it seems amazing. Patients have done clinical trials, one injection every 6 months, and blood pressures beautifully controlled. So it's a new technology. It's exactly as we've learned with the COVID vaccine targeting the RNA. All heard about the RNA strategy for vaccination. It's a very similar type of approach that is being used for hypertension. And we think that this is going to be an evolving era in terms of new approaches to treating hypertension. Yeah.
Right. So, I mean, going back to the vaccine, so is it something that's, because you said like hypertension sort of depends on like your lifestyle and, you know, how you carry yourself over an extended period of time. So a vaccine, sort of something we give, you know, I guess once or depending on the frequency.
Yeah.
So is this something that's going to be given on like vaccine you take every year, like the flu shot? Or is
Yeah.
it something that you get once, like it's like the measles or like the polio vaccine?
Oh, no. At the moment, they're talking about once or twice a year. So you'll need, because what happens is the efficacy of this agent actually reduces with time, and then you need to give a booster.
Okay.
So yeah, and currently that's what it is. It's still sort of early days, but it's hugely exciting for the world of hypertension. It's beautiful.
You know, if I do remember well, I think the daughter of Debbie Reynolds, she died of hypertension.
Oh, really?
Yes, I think it was because I started to
Yes.
watch for that.
Yes.
Yeah.
Yes. Many people do die of it, unfortunately. Many, yes.
So I'm just gonna, the last two questions that I had mentioned. So one is, considering the sex differences observed in hypertension, do you see the treatment of hypertension being sex specific?
Fabulous question. Fabulous question. You know, again, as clinical trialists and as physicians and as researchers, for a long time, clinical trials were done in men only for various reasons. And then the question started to be asked, you know, we're just extrapolating from the data from studies done in men to women. And now there's a whole new interest in doing trials, of course, in men and women. And some of the data is coming out to show that women actually need lower concentrations of some of the drugs to have the same efficacy as found in men. It's very interesting in Japan, for example, for all drugs, I think, because they have a different physiognomy, they tend to be smaller, body mass index is smaller. Every drug that gets approved there, trials are run in Japan. This, you know, trials that are normally done elsewhere would be done in Japan to address the specific physiognomy of their population. And we have to do the same now with men and women. So there is in the clinical trialists world, indeed, addressing women specific issues is very important.
Okay, and there are more questions, but I think we have to give our speaker a little reprieve after she's been talking for over an hour and 15 minutes. So I'll just wrap up. This is an interesting question. What is the association of blood pressure and chronic pain?
Well, it's very interesting because pain's obviously a very complex process, as is hypertension. Pain is associated with inflammation and production of all these cytokines and chemokines, etc. But it's also associated with activation of usually the sympathetic nervous system, for example. And we know that many of these factors also play a role in blood pressure regulation. So indeed, pain can actually be associated with an increase in blood pressure. We do see that sometimes it's a normal response to an acute event, like an acute injury. Blood pressure will go up if one's involved in a traumatic accident or something where there's pain. But there is an association between pain and blood pressure.
So I want to take this opportunity to thank you again for your very interesting talk. I think we all learned some new things, and we heard some of the wonderful new treatments that we can potentially anticipate having in the future. And I just want to get something from over here. So just on behalf of the Department of Family Medicine and on behalf of the St. James Literary Society, we just wanted to give you some salty, rich desserts to help increase your blood pressure.
Well, the good news, it says chocolate here, and I'm sure it's dark cocoa chocolate.
Yeah, it has to be dark.
That's very good for the blood vessels.
Yeah.
So that's very good. Thank you very, very much.
We really
Yeah,
appreciate
thank
you.
I just wonder, I have a problem with asiatic, and I just wonder if it could bring, my blood pressure higher because of that.
Of the what?
I have a problem with the asiatic,
sciatic.
and I just wonder, could it affect me?
If it's chronic, maybe not. It's more the acute, yeah.
So I want to just remind people that we have some refreshments. Please feel free to stay and help yourself to food and drinks. I want to thank everybody who attended by Zoom. We had, I think, well over 110 people on Zoom, Professor Touyz. So we really had an excellent turnout this evening, and we look forward to seeing you all next year at the next annual Hirsch Rosenfeld event. So thank you all for coming.
So much.
Thank you. There were so many questions. No, I think thank you.
If you don't have enough salt in your system, it's not good either.
You need a little bit of salt.
Yes,
you do
because
need
one day I went to the hospital, visit this person, and I thought that he had a heart attack or something. And the nurse, she said, no, it didn't have enough salt in the system. That's when I learned about that.
Oh, okay. But too much is not good.
Oh, I know. Believe you me, I'm really very careful about everything, and I walk almost every day. Believe you me, I'm 81, and
No, you don't look it.
yes, I am.
Because you do all these good things.
I try, and my problem was to drink water. Oh, this is very difficult when your body is not requiring water.
Yes.
Boy, it's difficult.
Yeah.
Believe you me, I know. I have 4 bottles in my fridge. Sometimes I drink it before I go to bed. So you can imagine at night. You do get up. The water, I mean, it's and
Thank you, Spencer.
very good. When I had a pain in my
Exactly.
And
very much.
department,
Gums,
yes,
yes.
and I started to read about it, and it was not like to me, it's mostly men, you know, but it says also women that are menopause. And then it said the water, and when I saw the water, and I started to drink water. It was terrible, you know. I was in some, I've been someplace, you know, I have to go to the washroom. Oh, no, it's very careful. I did, but this was not my body. It was not. I mean, very, very few times that my body was really asking for water.
Yeah, very important to drink water.
I tell everybody, I say, drink water, and many people tell me that their body is not requiring water, you know. I thought that was maybe different than other people, you know. But no, a lot of people told me, no, you do. I said, when you start drinking water,
Exactly.
you know, oh my goodness, yes. So we want to be well, you know, because it's, you know, I mean,
It's not, it's not.
We're on the same page, yes.
Keep up your good
thank you so much. It was very, very good.
Good, I'm very
And I'm going to go and take my.
You do that, yes. Yes, you do that. Yes. Thank you so much. That's
Yes, there you go. Integrating knowledge. You know what,
the systolic is the one that is more. We know that.
Sorry?
Yes, systolic.
No,
Which is
now. I think it was it's 80s, 90s. Did you manage to speak to
The diastole.
So are you just taking it?
I'm working on that.
Well, that's thanks so much for coming.
We'll get to see each other again.
Exactly.
How are you?
Good.
That too, yes, exactly. Very nice to meet you. Thank you for coming.
The team that's done tomorrow. No, that's
Thank you
right.
so much for coming.
The elder meeting. He's the one who gave me
But today is
I'll see you. Are you tired?
So what is your interest? What?
never had any of those.
But are you interested in doing work with patients or in a laboratory? So let me give you a comment. I'm going to drop your line. Very interesting. So just drop me a line and he can follow up. Sorry? Anatomy, okay. So I'm doing
I just finished my second. I'm not, I'm working.
Oh, okay, there we go. So my husband, he's teaching anatomy. I don't know if you met him, but he's been teaching anatomy. Mr. He just started in October. Teaching anatomy. You know what he's teaching? I was teaching the medical students and dental students.
Probably knows, like the person that I had this semester's Dr. Ben. But yeah, that's my plan so far for like my anatomy-based program. She was presenting.
And you also do your BSc.
And my bachelor's.
Very nice. And you also want to go into medicine?
Yeah. So interesting because like I feel like I knew a lot of stuff like the basics, so like the research part of like in the vaccine is interesting.
Yeah, it's all very it's really very
Even in my course, like I love learning about like research and stuff, like what's happening.
Yeah,
That was like really cool.
Yeah, well, that's good. So just have that your enthusiasm and your interest. Thank you for coming. It's very nice.
It was very interesting.
Bye, have a good night.
You too.
How are you?
Sorry, so my name is Maya. And now I'm doing the master's in Prevalence.
It's annual.
Oh, good for you.
Thank
Good
you.
for
I'm so
you.
happy. I'm interested because I'm excited.
That's wonderful.
Thank you. I just will go ahead. No problem.
Thank you for coming. Appreciate
There'll be
that.
other
Yes.
lectures, but not the Hirsch Rosenfeld lecture.
Okay.
There'll be other
Hi.
lectures.
Are you here?
Very good.
Okay, very good. Yes,
All right.
yes.
I'll come down.
No, Marie is the lady over there. That's
Maybe
Marie.
over there.
Yes.
All right. Okay, yeah. all right.
This morning. This
Okay.
morning.
Oh, yes.
C'est la francophone.
And the meeting.
Yes, I know, it's so much better. Yeah, so
I'm
the
so sorry. I thought you just make it to the
Oh, sorry.
So my supervisor right now is in the master's in Prevalence, which is